Bismillahirrahmanirrahim. Good morning. Today is 9th of September 2022. It's Dr. Abid Rafiq here, Pediatric Intensive Care Consultant from Fatima Memorial Hospital, Lahore. So today we have a topic in Pediatric ICU cardiac emergencies. So we'll take almost there are 5 or 6 pediatric cardiac emergencies in Pediatric ICU, and patient come with these symptoms and diagnosis in Pediatric ICU. Cardiac emergencies, they are the most common stressful emergency presentation for the parents. Cardiac problem in infancy and childhood are not rare, often are complex. Cardiac disease in infancy and childhood can be congenital or acquired. So we know a lot of congenital things presenting in early infantile age, but it can be acquired also. So what could be the acquired causes in infantile age? Yes, or even before, they can have acquired SVT other than the, related to the viral illness. Because mostly newborns, they present with tachycardia. I'm talking about patient who is less than like 3 months or 6 months, very small baby. So they can have myocarditis. Normally it presents between 6 months to 2 years. Before that, they can have neonatal SVT also. Or they may have congenital syndromes we'll discuss, and then they present with tachycardia, and you end up by diagnosing like long QT or WPW or other congenital related things. Or they can present with congenital heart block. So most clinically demanding pediatric cardiac emergencies presentation in infantile age: congestive heart failure, myocardial disease, neonatal cardiac emergency with obstructed systemic or pulmonary blood flow, or it can be hypoxic attack, like in, we call it a cyanotic spell in any cyanotic congenital heart disease, particularly tetralogy of Fallot. Cardiac arrhythmias, and the most common what we used to deal in pediatric cardiac ICU is acute post-operative pulmonary hypertension crisis. And I have given you people already example that what is the most common scenario, the patient who come to us. So I have done almost 15 years of pediatric cardiac ICU. So most common presentation, patient come to us in cardiac ICU with VSD or AV canal closure. And patient has a lot of pulmonary blood flow to present with before patient went to the OR. So patient has a high QP-QS ratio. And once you get that patient in cardiac ICU, they have severe pulmonary hypertension. So you may have to sedate, paralyze, hyperventilate and hyperoxygenate. And obviously, you may not extubate these patients in the next 48 hours once you receive in pediatric cardiac ICU. So there is specific management guidelines for these patients. And how you diagnose, the most important thing for the fellows, that these patients, they have hypoxia. In spite you are giving them 100% FiO2. Remember, these are cardiac surgical patients. They don't have lung problem. They have pulmonary hypertension because of the cardiac disease. So they present in the cardiac ICU with low PO2. Remember, if someone is receiving like 100% FiO2, if I put you on 100% FiO2 on ventilator, how much your PO2 should be? How much your normal PO2? Huh? Normal PO2 is 80 to 90 if you do for me arterial PO2. Okay? And if you put someone on 100% FiO2, even if you put on 40% on ventilator, PO2 can hang around like 200. And if you put someone on 100% with normal lung, they can have 450 PO2 on ventilator. So why I am saying this one? This is very important. Whenever you say, this is the blood gas of the patient, I have told you how to tell blood gas. You tell 7.4, 40, 40, 25. This is how you tell the blood gas. The first one is pH, the second one is CO2, the third one is PO2, and the fourth one is bicarb. You don't need to say, sir, pH is this one, CO2 is this. You just say 7.40, 40, 40, 25. So if someone has 40 of PO2 on 100%, that is hyperoxia fail, and that patient may have cyanotic congenital heart disease, if the lung is normal. All right? Because if the lung is not normal, you are dealing with ARDS. Then if someone has so much low, so I am just telling you, whenever you talk to us in ICU, you need to know how much patient FiO2 is getting. And that I know you guys have already grasped that concept in neonatal ICU, that whenever you are rounding with the even neonatologist, they are asking you how much FiO2 you are on. Because a lot of times you have FiO2 requirement going down or FiO2 requirement going up. So you have to tell the blood gas in relation to how much oxygen you are on. Once you are on ventilator, even sometimes you are nasal CPAP, or they are giving oxygen by nasal cannula. Nasal cannula may not give it's only give 30%. So also people need to know what are the oxygen delivery devices and how much maximum oxygen you can give. So nasal cannula 30%, simple face mask 40%, non-rebreathing around 80 to 100%, oxyhood 100%. Oxyhood you can give 100% oxygen if you give 8 to 10 liter, and there is a curtain like you put patient in the oxyhood and you give oxygen on 8 to 10 liter for 10 minutes, then you can have oxygen concentration in that oxyhood around 100%. But if someone asks you how to put patient on 100%, always it is by ventilator, mostly controlled. Because then obviously why the ventilator give? Because ventilator has an oxygen concentrator if it is functional. Lot of times the oxygen concentrator is not functional, and then there is alarm on the ventilator that there is an issue in the O2 cell, because that need to be replaced. So we know that in developing world we have lot of issues with the like biomedical also, but you need to know whenever you are talking about any PO2, we need to know what is the context you are talking about, how much FiO2 patient is on. So that is very important. So these patients, they show hypoxia. So heart failure is a syndrome in which the heart cannot maintain level of tissue perfusion adequate to meet metabolic demands. I have told you, definition of shock is very simple. It is a mismatch between oxygen delivery and demand. Demand is getting what this perfusion, my tip is getting, and so this tip is getting oxygen by blood, that is your cardiac output. And then tissue is using, this is your oxygen consumption for that area, and then coming back. So I want to give a concept here which people forget. So why I always tell, why the shock we monitor by mixed venous saturation, lactate and urine output. The most important thing to monitor any shock patient is how much your mixed venous saturation. And we take mixed venous saturation from the like SVC or central line. It should be above 70, that is the PALS guideline. What happens? Normally you give, so remember I told PO2 is how much for me? 80 to 90. Alright? So how much saturation we have normally? We have saturation like 94, 96. Alright? If someone put us on oxygen, maybe then we are saturating 99. If your saturation is 99, your PO2 may be like 90 to 100. But remember, once it is 100%, you don't know, your PO2 may be 400 or it may be 120. So it depends, because then you cannot figure it out how much your PO2. Once you are on 100%. Because if you put someone normal, like someone among us who has a normal lung, you put 30%, they can saturate 100%. But with 100%, you don't know how much your PO2 is. So it can be 450, as I told, on 100% FiO2, or it can be 120. So normal PO2 is 80 to 90, in a fully corrected heart. So what happens now, that normally you send here how much saturation to this area I am talking about. I just want to clear this concept of mixed venous saturation. Why we are so much interested? The mixed venous saturation is very important for us. So what happens now? You are sending blood, how much saturation here? Huh? Nee beta, 94. I have a 94 saturation. Na? So I am sending blood here with 94. Tissue is getting for metabolic demand, for aerobic metabolism, and then sending back to the heart how much? It is sending 70, 75. 80 is okay. So that is the reason in shock we talk about that we need to keep above 70. But what happens once there is a delivery problem, once there is a cardiac output problem, once there is a shock, then what happens? Saturation is coming 95 in this blood, but tissue is getting extraction more. What happens? Tissue is saying to the heart, okay, you are not justifying with me, you are sending less blood, I will give you less oxygen, oxygenated blood. So tissue is extracting more. Tomorrow I will explain you again this concept, but for my PGs, my resident and SR, this concept has to be very clear. Why we are interested so much. And oxygen extraction, it goes very early part of shock higher. Normally tissue is sending 5 times Heart is pumping blood 5 times more than the demand. Delivery is 5 times more than the oxygen consumption. But what happens in shock? Extraction increase. Once there is extraction increase, you are sending 50%. So that what we are checking. And where, so now how much your tissue is getting? 95 minus 50, 45% he is getting tissue. Because tissue is getting less blood, it is sending more deoxygenated blood to the heart. And why I am stressing this point? This is the earliest change in the body which you physiological pick. Because urine output and lactate drops later. Lactate rise build later, and urine output also drops later. So if you ask me, sir, what is the most important thing? Lab, because it's the objective, and I always talk about trend. Don't see one, one number. We need to talk about trends. Follow the trends in ICU. So you take that point. I mean, if 50 is coming, that means tissue is getting 45%, and that is shock. So this is what mismatch in delivery and consumption, and that is, this topic we do again and again at every level. So CHF can be divided into 4 types based on the underlying pathophysiology. It can be pulmonary overflow because of CHF can be because of pulmonary overflow. What is the example? Thank you very much. CHF due to impaired myocardium. What is the example? Thank you. CHF due to obstructive lesion. What is the example? Huh? Okay, excellent. Or, it can be obstruction to the veins also. But this is fine aortic stenosis. Or you have critical AS in the newborn area also. So they can struggle. Again, they will get a CHF. Tachyarrhythmia induced CHF. What is the example? Excellent. So these are the 4 lesions important which can present in pediatric ICU, and all you can see during your training in pediatrics, 4 years. I mean, these patients you see again and again, especially if you are in a big unit like Children's Hospital, daily you see all these 4 patients. So we know pulmonary overflow, most common cause of CHF is excessive volume overload, and now we are talking about left to right shunts. VSD, AV canal, and arteriovenous malformation. Remember, AV malformation can be in the brain, can be in the lungs, or can be in the peripheries, and they can present with a high output cardiac failure, with a wide pulse pressure, and then you have a differential diagnosis. So what are the precipitating factors exist that lead to decomposition? The most common factor is infection. Respiratory mortality is quite high, especially if you don't start cardiac failure treatment. So clinical manifestation, I think we don't need to spend much time on that one. So the most important clinical, if you ask me, what is the most important? They are tachycardic. They are tachycardic, they may not have gallop rhythm. Check the pamper, they are not passing urine. Any patient I round in ward or in ICU, I always ask 2 things, urine passing or not, and what are the medications. Because medication you are intervening, if you are giving wrong, you are causing iatrogenic damage. And if patient has some problem, then even simple diarrhea patient, they may not have urine, and patient need rehydration. And I have seen in my career, shock in the wards, shock in the ICU, mismanaged. Suppose if patient has diabetes insipidus, we have a lot of diabetes insipidus in Saudi Arabia, because there is a lot of neurosurgery program where I work in King Fahd Medical City, Riyadh. So patient is coming, patient has a diabetes insipidus, and someone is not replacing fluid appropriately. You know how tricky these patients. So once they are in the ICU, they are very difficult to manage. They are pouring a lot of urine, 8 ml per kg per hour. Lot of urine, 4-5 liter in 24 hours. So if nurses, they are not vigilant, and physician, they are not at the bedside, easily you can have shock in these patients, because they don't have ADH. Absolutely. So CHF present, so you see the heart, I mean, that's quite big. So for the PGs, this is plethoric lungs, cardiomegaly, okay, and even you can see the liver is enlarged on X-ray. So these are the 4 important findings if someone asks you in the exam, because this can come in just like your, that talks. So what is the management? Management is diuretic therapy. You do oxygen therapy for especially cases, but normally remember CHF, they don't desaturate. They don't desaturate, but they can have low saturation. Why?
Excellent. Tissue perfusion problem. So they may have errors in getting saturation probe. So then there is a role for getting PO2, arterial PO2 getting checked. Because if there is a perfusion problem, and what a body do normally, body release endogenously catecholamines. So if you have CHF in any patient, then what happens? You have a vasoconstriction and body warms in the core. Central temperature is high. Centrally hyperthermia if you put temperature in the rectum, and peripheral temperature is cold, 35. Central is 38. So 3 gap, and I have one presentation where I put there is a single one thing you can diagnose patient shock if there is a high temperature gap. Central, and this is what we do in cardiac ICU because both temperature they are on the monitor. So this is one of the topic tomorrow also. So basically temperature gap is very important. Whenever my consultant they walk at the bedside, they used to put hands on the peripheries in the ICU, cardiac surgeon, and they say, "Oh, Abid, this patient is very much vasoconstricted. Give some milrinone or divitamine if the blood pressure is fine." So this is how you decide inotrope vasodilator clinically. All right, because if you have a normal blood pressure and you have a shock, this is good because then you have a lot of grounds to play around. Because milrinone is good, we'll discuss tomorrow. So control of infection, digoxin is almost obsolete now, but you have to work with the afterload reduction. What is afterload reduction? It is capace, captopril, or maybe it's a milrinone, which also reduces afterload and increase the contractility by increasing the stroke volume. We know that one. Milrinone has a 2 function. It is a vasodilator, and more than that, it is a inotropes. All right. What is the definition of inotropes? Shabash. If increase the contractility, end up by having a more stroke volume. So anything which increases the stroke volume is inotrope. What is the definition of chronotropy? Rate. Dromotropy, conduction within the, and lusotropy is milrinone, diastolic relaxation. More diastolic relaxation, more end diastolic volume, better cardiac output. All right. These are the basic physiology of heart. Management of acute CHF will not go in detail, but only one lesson in management. Take care about potassium. This is the only lesson I want, especially potassium, because these patients they are on diuretics, and potassium is always low in these patients. So you have to keep eye, especially if they are on capace and digoxin. Keep eye on the potassium for these patients in acute phase. Once they go home, they don't have much problem because you send them on spironolactone. But acutely in ICU, we are talking about pediatric cardiac emergency. Potassium is crucial because they can have easily arrhythmia if your potassium is low. So the most clinically demanding pediatric cardiac emergency presentation, myocardial disease, and we talk about myocarditis. So congestive heart failure due to impaired myocardium, primary inotropic depression. And the cornerstone in these patients, I told before also, to reduce the afterload. Remember, if heart is not contracting, like there is a contractility issue, so what you can do, because there are 3 components of cardiac output: preload, contractility and afterload. So these are the 3 components to increase anyone cardiac output. This is what you do. You give volume or you optimize preload by giving diuretics. Contractility, dopamine, epinephrine you give, or you give milrinone or dobutamine to manipulate your afterload. But remember, if someone has myocarditis, the only thing which can improve is your afterload reduction, and which is by capace or acutely in the ICU by milrinone. But you need to have normal pressure. So people talk to me. Lot of time people say, sir, isko milrinone start karni hai ki nahi? Whether we need to start milrinone or not. If you have a normal pressure, start. If you don't have normal pressure, then epinephrine, dopamine is okay, but low dose. Because once you increase dose, what they happen to them? They are already tachycardic. So once they are tachycardic, what happened to the cardiac output? Once you are tachycardic, your end diastolic volume decreases, because you know the physiology. So we don't want tachycardia in these patients. So afterload reduction is cornerstone, but you need to have some pressure to play around. Give milrinone. And what I do normally, I give them calcium to get the blood pressure up. So we cannot give these patients volume. So I give them calcium chloride or calcium gluconate. Maybe sometimes I put them on like 8 hourly, 1 ml per kg per day. I mean, you need to keep eye on the ionized calcium. It is not going high. But calcium is very good inotrope. Sometimes you can negotiate by giving calcium and then putting milrinone, getting the diuresis and getting under control the signs of CHF. Cardiomyopathy and coronary perfusion abnormality. So what is the example, classical example in pediatric? Coronary perfusion abnormalities. And FCPS people, they need to know. Have you heard about L-kappa? Yes, L-kappa is the diagnosis which you pick 3 to 4 month old baby, come to you in pediatric OPD to the consultant, and that baby is sweating and taking a lot of times in feeding. And you do ECG, you find infarction, and you do echo, there is a big heart. And there is an anomalous origin of left coronary artery, and baby is getting coronary steal phenomena, and there is a coronary perfusion issue. You can read now L-kappa later on, but L-kappa we need to know. That is one of, it can be MCQs in your, so they present with myocardial infarction. 3 to 4 month old, they have recurrent myocardial infarction, they develop cardiomyopathy. So any patient who has cardiomyopathy findings, you talk about endocardial fibroelastosis on echo, or you need to rule out, the L-kappa for these patients. So you see how the heart enlarge in CHF, and also you have, like pleural effusion they are getting, and the lung is getting wet. There is, you see how much. So this is the echo view, and you see how big is. This is all LV. If I can put up a pointer for you on the screen, this is all, remember, so this is all LV. What happens? These patients, they get in the LV thrombus. So sometimes you have to anticoagulate them also. You guys know that if there is a depression in the myocardium, even in adults, there is a tendency to form thrombus. So these patients need to be on, sometimes acutely you have to give them heparin, and later on you have to give them warfarin. So this is all LV. You see how big is the LV? So management is the same as we discussed before. Diuretic, inotropic support, milrinone is better, and afterload reduction and oxygen therapy again. What, remember, if you give anyone oxygen, how it helps even in heart failure, how it can help? No, that is fine, but pulmonary vasodilatation oxygen in a patient who has already pulmonary hypertension. But remember, CHF patient, they don't have pulmonary hypertension. They have, plethoric lungs. Pulmonary hypertension, they have a black lungs. This is again. But what happens? Oxygen improves the oxygen delivery to the patient. Remember, I told you two things. Oxygen delivery contain what? Cardiac output and oxygen content, CaO2. I might tomorrow will discuss that one. So basically, if you cannot improve the cardiac output, for some time you can improve the oxygen saturation. So I give you example, like a lot of times you are asking me, sir, isko blood laga दूं मैं? If patient is quite sick in PICU. This is what you are asking me. Basically, what you are doing, you are telling me, sir, by giving blood, I want to raise my saturation. Oxygen content will be raised, oxygen delivery will be better, and patient can come out of shock. So this is one thing we are doing in ICU for these patients. So this is the detailed drugs for pediatric heart failure and effect they produce. I think we don't need to. So this is another one, newborn with collapsed systemic circulation or intense cyanosis. Emergency intervention is crucial. So newborn with obstructed flow, heart failure due to obstructive is almost always associated with left-sided lesion. So what it can be? Preductal coarctation of aorta, hypoplastic left heart syndrome, interrupted aortic arch. Remember, you can get MCQs in your FCPS written exam. So these patients, they present with shock. They have low urine output, shock, ashen gray color. They are not cyanotic. They are ash colored. They might give you, and they are shocky newborns. And obviously 72 hours, they need like couple of days before the duct is closed, because they have a duct dependent systemic circulation. Shabash. So they have duct dependent systemic circulation. We have duct-dependent pulmonary circulation also. What are those lesions? Pulmonary still critical PS or pulmonary atresia. What else we talk about? Tricuspid atresia, duct-dependent pulmonary circulation, in which you open the duct by giving prostaglandin and you have a better saturation. And we have duct-dependent systemic circulation. These are the examples. Just I put coarctation of aorta. Absolutely. This is important. Hypoplastic left heart syndrome or interrupted aortic arch. So how they present? Shock, pulmonary edema, cardiogenic shock. And this is duct dependent. You see circulation now. So if you ask, tricuspid atresia is duct dependent pulmonary circulation. Hypoplastic left heart syndrome, shabash. Pulmonary atresia with intact IVS, duct dependent pulmonary circulation. Pre-ductal coarctation, systemic. Interrupted aortic arch, critical AS, systemic. Duct dependent. So these are the two types of lesion where you give prostaglandin. Unfortunately, we don't have in Pakistan, but at least you need to know, because this you can get MCQs. This is very things are not present now in Pakistan, which used to be present before, and this is life-saving. So coarctation, it's quite common, and it has a variable presentation. And it can present in newborn age, and it can present in infertile age, or it can present even in adolescent, just with high blood pressure, because of the collateral, and so it has a variable presentation. Evaluation of infant pulses is the most important part of physical exam. Absent femoral pulses, or there is a radiofemoral delay. Remember, radiofemoral delay comes late. If you have like 4 to 6 year old baby, then you can feel the radiofemoral delay. Otherwise, difficult to pick radial femoral delay. So radiofemoral delay comes in like childhood, above childhood, like 6, 8, 10 year old, adolescent age. Before that, you have a feeble femoral pulses, and you have a good brachial and radial pulse. All right. So it is important. 5% of that was actually my dissertation topic during FCPS. So I have done my dissertation on coarctation. So it's almost 6% of total congenital heart disease, and more common in males. Hypoplastic left heart syndrome. Embryologically, left-sided structure, they are hypoplastic. All right. And what procedure these patients they get? Just the procedure name. Hypoplastic left heart syndrome, how you deal with them? Norwood procedure. Just you need to know that. I mean, they get Norwood. They have a 3 stages, neonatal, infantile, and then childhood. In the newborn, you do, depending on the pulmonary circulation, you do BT shunt or PA band. In the infantile age, you do Glenn. And at 2 year old, you do Fontaine completion. And this is the pathway we call it a Norwood procedure they get in the newborn age to fix the hypoplastic left heart syndrome. And they present like duct-dependent systemic circulation. So they have a shock, they have a low urine output, low mixed venous saturation, and high lactate, and present early after 72 hours. Incidence in the newborn 8%, most common cause for early cardiac death. Presentation first 1 to 3 weeks of age. Pulmonary atresia. So what happens now? You see here. So this is your LV. This is your veins coming to the LA. This is your right-sided chambers. So this is RA. Both great veins, they are draining into the right atrium, and then this is your tricuspid valve. So you see how rudimentary is your RV, because what happens? If during embryologically there is no outflow, there is outflow tract obstruction, the chamber will not develop, and it has rudimentary, and then obviously, so this is a patient. So you have 2 types of pulmonary atresia. You have intact septum, and you have pulmonary atresia with VSD. So this patient has what? This patient has intact septum. We call it IVS. You can find in the books pulmonary atresia with IVS, intact ventricular septum. It is written in Nelson whenever you read for those cyanotic heart disease patients. Okay. So what you do for these patients? They present to you in the newborn age with cyanosis. So what you do for these patients? You do BT shunt, okay? You do BT shunt. And you do modified BT shunt. We will not go into detail what is classical and actually this is all, I have seen these patients tons of times, multiple times. So at least you need to know hypoplastic left heart syndrome, how it present and what procedure they get. Arterial switch is for transposition of great arteries. For pulmonary atresia, if it is obstructed blood flow to the lungs, you get BT shunt. If someone has increased pulmonary blood flow, there are a lot of diseases. What you get? You get PA band, pulmonary artery bending, to reduce the pulmonary blood flow so there will be no end stage vascular disease. Management of duct dependent lesion, prostaglandin is the standard medical intervention. Inotropic support needed. Ventilator support also, especially if they present early, they are in a bad shape. Hypoxemic attack, this is relevant. You can get in your talks FCPS exam. So what is your previous knowledge of managing these patients? If you get a patient like 9-month-old, like 1-year-old babies, they get cyanotic spell. Patient is a known case of Tetralogy of Fallot, and they present to you, in a very bad shape. So how you would like to approach that patient? Shabash. Position, oxygen. Huh? No, diuretic. In these patients, you have to give them a lot of fluid. 1.5 minutes, like tumor lysis syndrome. So you have to give them more fluid. You get cannula, but initially you calm them down. Because while getting cannula, they will be more cyanotic. Because first you try to calm down. Maybe you can give them oxygen, calm down, as she said, squatting position. And then you try to get cannula by expert person. And then you give them bolus, IV fluids. You can give them bicarb. And then there is a lot of management like IV propranolol, IV morphine. But basic steps you need to know. What are the basic steps? Removal of pain, oxygen, IV line, hydration, and squatting position. These are the basic steps and bicarb, these patients. These are the initial steps. Then obviously you can give them vasoconstrictor also, like dopamine. You can give them tolozolene, propranolol, morphine. Morphine is drug of choice in these patients, and it is written all in the Nelson. So these are the basic steps of management of cyanotic spell in Tetralogy of Fallot. Any patient who has compromised pulmonary blood flow because of some congenital heart problem, they can have cyanotic spell, but mostly Tetralogy of Fallot, they have more tendency. And the underlying factor is iron deficiency anemia and polycythemia. There is a lot of underlying factors, but this is cyanotic spell. So this is how they present. Bluish skin during episode of crying or feeding. Tet spell, you call it. So this is Tetralogy of Fallot. So what are the 4 components of Tetralogy of Fallot? Huh? So VSD, you have perimembranous VSD. You have outflow tract obstruction with the right ventricle. Then you have a right ventricular hypertrophy and overriding of aorta. And this is the patient. So you see, the most striking thing in the X-ray, the lung is very black. What you call this lung? Oligemic lung field. You can write oligemia. You can write in the talks also, because sometimes they give you black lungs like this, and they will going to ask you what are the findings on X-ray. So you write oligemic lung field. If someone has VSD or AV canal and the lungs are very white, we call it plethoric lungs, increased pulmonary blood flow. This patient, they have a decreased pulmonary blood flow, and normally Tetralogy of Fallot, they have a normal heart size. This heart looks generous, maybe because of the thymus coming also. This patient is a small, but remember, also Tetralogy of Fallot. This is a pediatric cardiology fellow level question, but they can get cardiomegaly, Tetralogy of Fallot also. But we will not discuss that one. Remember, they have a normal heart size, even sometimes small. Oligemic lung fields, and they might have 25% cases right side aortic arch also, Tetralogy of Fallot. Pulmonary atresia, we discuss also, and obviously they end up by having a shunt. Hypoxemic attack. So there are triggers, mostly triggers the fever, intercurrent infection, dehydration, clinical findings, sudden onset of labor, breathing, irritable. Management we have discussed, calm the child, oxygen, sedation, establish intravenous access, correct acidosis, bicarb, pharmacological therapy, propranolol, and ismalol infusion, but propranolol is still drug. So what you need to do, everything you need to do to get the SVR up, so that the shunt get reversed, because there is a shunt going on. So what is SVR? Systemic vascular resistance. Get your blood pressure up, the shunt will be less, cyanosis will be less, and baby will get out of. So you need to give them dopamine, hydration, morphine, propranolol, or get the SVR up, and they have shunt reverse. Emergency, I have seen patients in which you have to do emergency BT shunt. You do everything, even you ventilate them. And every time, once in a month, we are getting in children hospital, one patient in a month where nothing worked for TET spell. Because patient Usman comes very late here in Pakistan. And the more you are late, the more polycythemia you have, and they get CVA, cerebrovascular accident, because of the poor management delay. I have seen so much CVA in children hospital, uncorrected, which we don't see outside, because they repair early in like Middle East. They get early surgery, and then you have a less complication. But still we have people who don't want to go with surgery, and still you see all those complications. And CVA and brain abscess, these are the two major complications for tetralogy of Fallot. Other than infective endocarditis, you can write down, these are three major complications related to cyanotic heart disease: brain abscess, hemiplegia, and infective endocarditis. These are the three complications particular to cyanotic congenital heart disease because of their underlying risk factor. This is the last cause for CHF in the ICU, and because of tachyarrhythmia, disturbance in cardiac rhythm are relatively common in infant children. Increased incidence, especially after post-cardiac surgery patients. So, infants, you need to know the normal heart rates. But in small baby, anything above 200 is not good. And in older children, you put a point like 160. So, and then you need to see whether it is sinus tachycardia or whether you have non-sinus tachycardia. Conduction system we know. So pathophysiology, most children with rhythm disturbance, no cause is recognizable. Some CHD has relative high incidence of arrhythmia. We are finishing now. Corrected TGA, abstain, congenital mitral stenosis. Post-surgical repair, tetralogy of Fallot, they have more. Tetralogy of Fallot, they have a heart blocks more, and they have more right ventral branch block issues. Also, they have more jet acutely in the ICU. Junctional ectopic tachycardia. Transposition of great heart. These are the patients who get surgery and then they have more risk of getting a rhythm issue. And Fontaine procedure, as we talk for the single ventricle physiology. Acquired heart disease, cardiomyopathy, viral myocarditis. Viral myocarditis, the most common cause of death in myocarditis is because of arrhythmia. Because of, these patients, they get rhythm problem. Cardiac tumor, rheumatic carditis. Systemic disease can lead to and other than electrolyte problems, you can have like thyroid storm or other problem. Drugs, theophylline, digital toxicity can lead to the rhythm issues. So features of sinus tachycardia and supraventricular tachycardia, you see. So what happens in heart rate? In both, heart rate is high, but more high in supraventricular. Heart rate variation is absent. It is present in sinus. P wave on ECG present mostly, but most absent in SPT. Response to adenosine, no response. And mostly they can respond to adenosine. Some SPT, they don't respond to adenosine, you have to give them shock. Also, adenosine has a guideline. If patient is in shock, you have to shock. But remember, if you are shocking SPT patient, you have to give synchronized or unsynchronized. This is my question. Synchronized. Because unsynchronized, you give in which disease? You give in ventricular tachycardia or ventricular fibrillation, unsynchronized. Okay? But synchronized, you have to give in SPT. You have to put button on the shock machine. Manifestation, they present with shock. You see here WPW, the PR interval is short and there is a slurred upstroke. You see this patient, lead 2 is the best one, and you can see this is a slurred complex noted in lead to AVF and V through. So they have a short PR interval. Again, you see the lead to, this is the lead to, this one. Long QT. So mostly if corrected long is QT, how much is the normal QT interval? It should be less than 0.44, 0.46 sometime in adults corrected. If it is more, they have also association with the deafness and other long QT, and they can have sudden cardiac arrest. And if you diagnose these patients, what is the management for these patients? No, you have to put ICD. You can write down ICD. This patient, they need, you do them Holter. If they have frequent ventricular tachycardia rhythm, you have to put them, these are the candidates for ICD. Okay, you put them, implantable convertible device, because they can die suddenly, and they need emergent. If you diagnose, if you on Holter, you do 24 hours Holter monitoring for these patients, and if they have symptomatic, if they are runs of VTAC on, you read that Holter, and then these candidates, they are candidates for ICD emplacement. This is the last pulmonary artery hypertension we have discussed already before, and how they present these patients pulmonary hypertension, hypoxia, and they have a known disease, VSD or AV canal, and you have repaired them. They come to the ICU, and you have to hyperventilate, hyperoxygenate, sedate, paralyze, and extubate relatively later, if they have preoperatively high QP-QS ratio. And what is high PQ-QS ratio? Anything above 3:1. And this is also a surgical indication for VSD closure. They can ask you in FCPS exam for VSD closure indication. Pulmonary hypertensive crisis, again, this is the same management for pulmonary. You sedate, paralyze, ventilate, give them more oxygen, milrinone, and later on sildenafil at home to deal these patients. I think we just need to finish now.